of labor. So make sure that you commit that to memory. All right, so when a patient comes in and they're in latent phase of labor, we said one of the big things that we have to do during that phase is going to be to do an admission assessment. So some of this stuff we would do for other patients as well, but some of it's going to be specific to our labor and delivery patients. One of the first things that we need to ask them is about gestational age. So how many weeks pregnant are they? Typically we have prenatal records, and so we can look that up. But that's hugely important, because if we don't know how far along they are, their just weeks of gestation can drastically change our plan of care. So let me give you an example. If you had a mom and she came in and she was 28 weeks pregnant and she's contracting every 2 to 3 minutes, then our plan of care for that patient would be to stop her labor. But if you have a mom that comes in and she's 39 weeks pregnant and she's contracting every 2 to 3 minutes, then she's safe to continue labor because she's full term. So the gestational age will definitely play into what we're going to be doing for the patient. We need to know which physician she's been seeing with her prenatal visits so that we can make sure that we call the provider that is the correct one, or at least the one that's on call for that doctor. You're going to look at age and other risk factors. So this is where a lot of that antepartum stuff comes in. So I do want to mention a couple age things. So if they are an adolescent, that is automatically a red flag for us, just because it carries a higher risk of preterm labor, and then support systems may not be in place. So an adolescent pregnancy would qualify as a risk factor, but also if they're 35 years of age or older, which I know is not old, but by pregnancy standards, what we do know is that patients that are 35 years old or older tend to have higher risk for chromosomal abnormalities, especially Down syndrome. So young age or 35 and older would be a risk factor. You're going to look at all those things in their prenatal record, their OB history, and see if there's any other risk factors that you can identify. You will review all that prenatal lab data. So you can have questions on tests from antepartum labs because they follow them all the way through the pregnancy. So that could be rubella, group beta strep, because that's going to affect whether or not they need antibiotics during labor. So all of those things that we're discussing antepartum are going to come back into play. What their blood type is. So do they need RhoGAM? If they have a rubella that's not immune, postpartum is going to need to give them a vaccine. If they have group beta strep, then the labor and delivery nurse is going to need to give them antibiotics during labor. So all that is very, very important, and it's just kind of we run through all of it and make sure that we have all our ducks in a row. You would also assess allergies. So the treatment of choice, if they are group beta strep positive, is going to be penicillin, and we'll give it to them during labor. So it's important that we assess allergies and make sure that there's not anything that they're allergic to that we might potentially be using. So betadine would be another one, because we use that in our Foley catheter kits if they're going to get a Foley. We're also going to go over expectations during labor, which kind of goes over that birth plan that we mentioned in antepartum. We're going to discuss feeding method, if they're going to breast or bottle feed, because that may change the medications that potentially anesthesia or the nursing staff would give the mom. We're going to look at the weight pre-pregnancy versus current to see if they gained the appropriate amount of weight or if they gained too little or too much. We're going to look at their previous pregnancy history to see if they had any problems. Did they have a previous C-section? Because that could change the way we're going to deliver this baby. Did they have 2 or 3 miscarriages, and this is the first baby they've carried to viability? So anything in their prenatal history, that would be a red flag. We're going to see if they had prenatal care. So there's not, we in labor and delivery, we're kind of used to expect the unexpected, but we don't like to see patients come in without prenatal care. We're kind of flying by the seat of our pants at that point because we don't know even gestational age. So hopefully all our patients would have prenatal care, because that would be ideal, but we do have some that do not, and so you're kind of going in blind because you don't know what their gestational age is, you don't know what risk factors they have. You'll also want to consider cultural and religious beliefs. So my biggest thing with that is just to ask if you don't know. It's much better to ask in a respectful way than just to assume certain things about certain different cultural or religious groups. So it's always better to say, is there anything during your hospital stay with your culture or your religion that I need to be mindful of so that I can provide better care to you? That's a respectful way to ask, and usually patients are very receptive to you asking because it shows that you respect what they believe, even if you don't necessarily agree with it. You'll need to ask about preferred pain control method. Do they want to go natural? Do they want to have IV pain medications? Are they wanting an epidural? So it really does depend on what they want. So we'll kind of plan as best we can for what they want. Now just be mindful that natural means different things to different people. So natural to some patients means I just want to have a vaginal delivery, but please give me all the pain medication you can. Whereas natural to other patients may mean they don't want any pain medication. So we need to ask what specifically are they going to do for their pain control during labor. We'll look at their support system. So very important for all of our pregnant patients to see what their support system is. If there's some question as to whether or not they have a good support system, we can always make a social service consult to evaluate that. Adolescent moms are always going to get a social service consult so that we can evaluate their home situation to make sure that it is safe and they have the support that they need to be able to care for the baby. We also look for signs and ask questions about suspected domestic abuse. It would be, I wish I could say that pregnancy makes domestic abuse better, but it really doesn't. The statistics will say right the opposite, that there's more domestic abuse with pregnant patients than if they're not pregnant. So it's very important that nurses are very aware of what's going on with the patient or if there's any red flags. So typically when you think about red flags for domestic abuse, you're going to think, oh, well, their significant other is going to be, very aggressive and very rude and very over the top, but that's not always what we see. Now you could see that, but something else that you might see that you might not necessarily consider a red flag is a partner or a significant other that is very always by their bedside, doesn't want to leave them, answers questions for them, is almost doting to the point that it's over the top. That can also be a red flag and a sign of domestic abuse. So typically what we do is at our hospital, and every hospital has their own little policy for this, is that when we admit a patient into labor and delivery, the family is asked to step out for a few minutes to allow the patient to change, and so we would do our domestic abuse screen while there's no one in the room so that they would feel more comfortable answering questions if they were in a situation that they needed some help with. Functional needs are going to be assessed. So do they have a car? Do they have financial means to support the baby? Do they have transportation to doctor's visits? So we would look at all that so that we have time to kind of get some things in place if there's some issues, and that would also indicate a need for a social service consult. We already talked about adolescent moms. Next thing on the list is going to be to screen for PIH. So this PIH stands for pregnancy-induced hypertension. It's not going to be one of your exemplars for this semester. All of our patients get screened for it with every admission. The new term for it is gestational hypertension. It kind of goes back and forth. So we would screen for that, but that's going to be something that you'll learn more extensively about in 211. We're going to ask them about current medications that they're on and any drug use, including tobacco. So do they drink, smoke, do any kind of recreational street drugs? So you'd be surprised how many times we get a positive answer on that. If there's any doubt or there's a history, the physician can order a drug screen on the mom, and we can assess to see if there's anything that pops positive on that drug screen. The last thing that we also need to be aware of is the placental location, which sounds kind of like, well, why do I need to know that? But in some patients, the placenta can be sitting directly over the cervix, and if that's the case, a vaginal exam could actually cause more harm than good. So placental location should be anything other than over the cervix. So it can be fundal, meaning it's implanted at the top of the uterus. It can be anterior or posterior, but it should not be what they would call a placental previa, meaning that it is sitting on top of the cervix. We would need to confirm that before we perform a vaginal exam. All right, cultural care during labor and delivery. I already told you you should just be very mindful and be respectful and ask the patient if there's anything. I'm going to talk about a couple things that I've seen in practice. So with your Hispanic population, a lot of times they are Catholic. They don't tend to get epidurals. They don't tend to have the baby circumcised. So they also have a belief most Hispanic patients follow a hot and cold theory of medicine. And so typically they will not take cold beverages or cold things during labor. So for us, we give ice chips and popsicles when they're in labor because they may have to have surgery and we don't want them to aspirate, so we don't give them a lot of food. And so for our Hispanic patients, they may decline that because ice chips and popsicles are cold items. And then in the postpartum period, instead of requesting water or Sprite, they may request hot chocolate or hot tea because they need a warm liquid. Your Chinese population, when we see those in our area, a lot of times the biggest change or biggest thing that we see in that population group is that they believe in a rest period post-delivery, and labor and delivery nurses and postpartum nurses, we're trying to get them up, trying to get them moving. We don't want them to have blood clots. And so sometimes that is a little bit of a struggle if they are trying to enter that rest period and we're trying to get them up. So be mindful that that may be a cultural variant. It's not that they're just not getting up. That may be a belief that they have, and it may be something that you need to educate them about. And so if they're not going to get up, then we need to be doing interventions to prevent blood clots, like putting SED hose on the patient when they're in bed to prevent those complications that we know they're higher risk for. Muslim patients I didn't put on here, but just remember your Muslim patients are going to be very, very, very modest. They're going to usually want a female health care provider. Their husbands don't typically attend the delivery. A female family member, if they are there, is usually the one that will be their coach during labor. So just because the significant other is not there does not mean that they're not the one that you would need to include them in conversations about plan of care, but they may not be at the bedside the entire labor and delivery process. Any of these patients, regardless of culture, if they have certain jewelry on, sometimes we'll call those amulets. So if they have certain jewelry on that they want to have, as long as it's not a safety issue, which most of the time it's not, we can't allow them to have their jewelry left in place. Your Muslim patients also tend to be very vocal during labor, but not to say that some of these other cultures can't be, but your Muslim cultures do tend to be a little bit more vocal during labor as well. Your pain management options during labor. So you typically have your non-pharmacological means and your pharmacological means. We're going to do the non-pharm stuff first. So this is going to be anything that you would probably have in a holistic childbirth class. Massage, guided imagery, go to your happy place, breathing techniques like Lamaze and Bradley, aromatherapy. There's even something called effleurage, which you probably do if you have kids and they have a tummy ache and didn't even realize you were doing it. But it's just the act of making a light figure 8 motion on someone's skin, but that can be very soothing. And so effleurage can be done to help with pain management. So there's lots of things that we can do. We can do position changes. We can put them on a birthing ball, which basically looks like just a big exercise ball, and it allows them to kind of rock back and forth and kind of rotate their hips, which can be very soothing during contractions. We can put them in a rocking chair so they can rock back and forth. That gives them something to do with the pain. We can put them on the peanut ball. So the peanut ball is exactly what it sounds like it is. It's a big inflatable ball that's shaped like a peanut. So I guess it's not really a ball, but it's shaped like a peanut. It's very helpful for relieving tension in certain areas. It's also very helpful for promoting the baby to enter the pelvis correctly. So the peanut ball is kind of our best friend. All right, as far as your pharmacological means of pain management, the two biggest ones that we're going to have are going to be IV narcotics or some type of intrathecal medication. So your IV narcotics could be Stadol, it could be fentanyl. There's a lot of different ones out there, so it's really more physician preference as to which one they use. Now, that being said, you're still going to do your normal assessments that you would do on anybody that you're giving IV narcotics to. Their respiratory rate, depth, what their pain level is. All of those things you still have to do for your pregnant patients. You're just going to add a couple additional things to it. So if we're giving IV narcotics, you've probably had test questions on narcotics since pretty much day one of nursing school. They can cause respiratory depression. They can cause sedation. It's a big safety issue if they're getting up moving around. So for a baby, some of that does carry over to them. If you give mom a narcotic, you're essentially giving the baby a narcotic. So it's going to have the same effects on the baby. It's going to sedate your baby. So before we give an IV narcotic in labor, we need to do a cervical exam and make sure that delivery is not imminent, because then we're going to have a baby that's born very sedated and require a lot of extra interventions that we don't really want to have to do on a baby. So before you give the IV narcotic, you need to do a cervical exam, or the nurse needs to do a cervical exam to confirm that the delivery is not imminent. The second thing that we do for our pregnant patients is the timing of that IV narcotic. So if you're giving IV, let's say fentanyl, you're going to give it after you've checked the cervix and done your assessment, but you're going to give it at the peak of the contraction. So you're going to give it slow IV push during the peak of a contraction, because at that period, that's when all the vessels in the placenta are vasoconstricted, so it will limit the amount of narcotic the baby gets. So check the cervix and give it slow IV push at the peak of the contraction. The last time the narcotic was given needs to be reported to the nursery nurse at the time of delivery. So if something happened and her labor progressed really quickly and you gave fentanyl an hour ago, that should be one of the first things that the labor and delivery nurse tells the nursery nurse that's coming in to take care of that baby. And just like with your adult patients, if that baby's born sedated, then the drug of choice to reverse that would be Narcan. There is a caveat to that as well. So for your babies that have moms that are heroin addicted or some type of opioid addicted, you do not give Narcan to the babies. So if you had a mom that came in and she's a heroin addict and she delivered, that baby is essentially on heroin as well. And if you were to give the Narcan, it would reverse the heroin in their body and put them into withdrawals, which can be very, very, very traumatic and devastating to a baby. So if they have a history of drug use, then the baby can't get Narcan. They would just get respiratory support. We have to go through a process and they have to be weaned off of that medication. All other babies, that's fine. They can totally have the Narcan. Totally fine. All right, your intrathecal medications. This is going to be your spinals and your epidurals. So typically spinals are going to be used just for your C-sections that are scheduled. Your epidurals are going to be used for your patients that are in labor, and they can be used for a C-section if needed. So with your spinals and epidurals, I'm just going to kind of hit the high points, and then when we do the class activity in your Zoom meeting, we'll apply a little bit of this. With either one of these, you're going to need to have a consent form. This is an invasive procedure, and it does carry some risk. So you need a consent form signed. So usually the anesthesia provider is going to be the one to get it signed, and the nurse can witness it if they're not the ones witnessing it. You're going to need to have some lab work drawn on the patient. So what you're looking for is a platelet count. We typically just do a CBC count and look at the platelet. They need an adequate or relatively normal platelet count to be able to safely have one of these procedures done. And the biggest side effect that we see is going to be hypotension. So to counterbalance that, we typically give them a fluid bolus of anywhere from 700 to 1,000 cc's of fluid. So they would get a fluid bolus of 700 to 1,000 cc's. Now if they have hypertension or a history of renal failure, then we usually still give them a bolus, but you probably wouldn't give quite as much. During the procedure, the nurse is going to be responsible for monitoring the vital signs on the patient and keeping the patient in the correct position, which is going to be kind of a hunched over dangle position. They're kind of on the side of the bed with their back poked out, which we'll go over in your Zoom meeting in our case study. They will need to have a pulse oximetry monitor placed, and you'll also put a blood pressure cuff on the patient. One of the complications that can occur with this medication, which is very, very, very important for us to avoid, is that what they put in the patient's back, so this is